Benner, and this is the Shelbourne Knee Center podcast. We're here with Scott Bauman, my co-host tonight, for another episode covering another joint replacement and knee replacement topic with another great guest. So thank you for joining us. If you want to find us, you can find us wherever you get your podcasts. You can find us on social media, on Twitter and Instagram at the SKC Podcast. We have a Facebook and YouTube page for the Shelbourne Knee Center podcast. You can also email us if you'd like to ask us any questions or suggest any other topics you'd like to hear about at the SKC Podcast at gmail.com.
If you haven't, we highly recommend you go back to last week and listen to the episode. We had a great guest on. We had Claudette Lejeune from NYU in New York City, and we talked about something we really haven't discussed yet on the podcast, a little bit different of a topic. It was the ethical considerations of declining surgical intervention, and it was really balancing the mix of the medical, legal, and financial implications of taking care of patients in the orthopedic setting, especially with the high-risk population. So if you haven't, before you listen to this episode, go back to last week's episode and listen to Dr. Lejeune discussing that topic.
If you heard that or any of our other topics and you like to leave us a 5-star review or a comment for those that come behind you, please do that as well. Tonight, we're going to be talking about DVT prophylaxis, VTE prophylaxis, and joint replacement. And this all comes from JBJS article that is now in press. Low-dose aspirin is the safest prophylaxis for prevention of venous thromboembolism after total knee arthroplasty across all patient risk profiles. And I know this is something that I haven't made the jump to yet and using aspirin as my DVT prophylaxis, and I read this study with great interest to see whether it might change my mind. So one of the authors from that manuscript is on the show tonight. Dr. Atul Kamath is at the Cleveland Clinic in Cleveland, Ohio. He went to medical school at Harvard Medical School, followed that up with a residency in orthopedics at the University of Pennsylvania and a fellowship in adult reconstruction at the Mayo Clinic. He's the director of the Center for Hip Preservation at the Cleveland Clinic. He is a professor of orthopedics at that institution, as well as Case Western Reserve University. And he is a clinical innovation lead for Orthopedic and Rheumatologic Institute at the Cleveland Clinic as well. So, Dr. Atul Kamath, thank you for coming on with us tonight, and we appreciate being able to have you on the show.
Thanks for having me. I'm excited to talk about this topic, and hopefully I can convince you to switch to aspirin here.
Absolutely. So tell us about how you became interested in this topic. Kind of what was your way into this specific topic from a research perspective?
Yeah. Now, DVT prophylaxis, I think, is such an important topic, though, just orthopedics in general. And I think obviously joint replacement, given some of the higher risks with patient population and the nature of the surgery, I think it's important to kind of continuously look at VTE, DVT prophylaxis. I do think over the last couple of decades, prophylaxis has come a long way. Just in general, we're continuing to explore it, but I think looking at certain types of DVT prophylaxis, such as Coumadin, and which had been highly used, in orthopedics and joint replacement, in the last decade or so, as kind of in certain centers has kind of fallen out of favor. And then you look at other ones, novel anticoagulants that are have really grown in popularity in the cardiac space and other surgery spaces. And then obviously have made their way into orthopedics. So you have these different major trends. And throughout this time, aspirin has been a choice of DVT prophylaxis. And certainly from the standpoint, the goal was to understand temporal trends over time of using aspirin, but then kind of to look at it, versus maybe more historical, but then also specifically for this paper, some of the more newer anticoagulants, and just really look at it specifically in low and high risk populations. So the topic being very complex, the basic goal and the interest of our group was to look at the utility of using aspirin. It's simple, it's cheap, it's predictable, using it in low risk and high risk populations in joint replacement, and looking at that from that perspective. So, a personal interest of mine was to see that, because my practice, and it probably sounds like it differs a little bit from yours, is to use, aspirin as almost the default pathway. Mm-hmm. And again, just taking it. So it's a personal interest to see how that fares. And then also just broadly to see some of the trends in orthopedics, and, not just safety for protection, but, other things like complications and hospital admissions and other sort of health systems type questions. So a number of questions were kind of sparked by using this topic. But again, that's sort of the overarching theme of why we wanted to tackle this particular.
I have medical students with me every month, and this is a topic that I try to cover every month with medical students, just because it allows me to talk about a bunch of different things that I want to talk about over the course of their month-long rotation with me all at the same time. Obviously, I want to talk about risk factors and complications that can happen from orthopedic surgery, and just kind of general surgical principles, of which DVT prophylaxis is a really important one, especially with lower extremity surgery. I want to talk about the pharmacology of all these different agents. So I have them look them up, and then they tell me what they found, and I see if I can remember if that's right or not before we move on to the next topic. And just talking about the pluses and minuses of each of those when they try to put it into practice. I then put it on to them as a way to talk about research. Also, is if you're going to design a study for DVT prophylaxis, how would you design it? And one of the reasons I like to talk about that is because this is not an easy topic to study effectively and to get any good information out of, for something that is relatively uncommon, like venous thromboembolism after surgery, relatively speaking anyway, and to have so many different agents that are possible DVT prophylaxis agents that you could study to design a well done level 1 randomized controlled trial with several different agents. You would need thousands of patients to be able to show any statistically significant and or clinically significant differences. Just presents some challenges from a research perspective. So kind of give us a little bit of background for what's out there, and before you did this study, kind of what's out there that led you to say, you know what, here's the way I think we can look at this problem differently and hopefully answer this question.
Yeah, I think that's great. And I think, what's exciting about your research group is you're, continuously looking at these topics, and a podcast like this is a phenomenal way to kind of explore different topics. But you're right, it's a complex topic. And we took it from the perspective of, can we use a large multi-center database? I mean, this study, I don't know, I don't recall exactly, probably at least 60 centers were involved in the data that was culled for this study. But when we're talking about looking at a collaborative network that includes almost 90 million patients, I mean, this is a way we said, listen, we don't have the budget, and also, there's challenges to trying to do some sort of very large scale prospective trial. So we said, let's take a fairly thorough database, with enough power to do some propensity score matching, and then, tease out those buckets, like I said. So I think, and hopefully we'll go into challenges of this particular study design, but I do think there's challenges to anything. But we thought, hey, let's use a large data set. Let's try to tease that out and get enough patients in enough buckets to get some meaningful answers. I do think also, there are some historical, predicate trials where, a particular novel anticoagulant or a particular DVT prophylaxis medicine was used in a level 1 prospective, a blinded trial. But again, for me, it's, sometimes those studies, are just biased to looking at 2 different medications, or did not include an aspirin arm per se, or just, high risk patients. So we wanted to also be taking, low risk patients, high risk patients, taking patients on different medications. And again, that for us required looking at a very large database. I would also say that some of the studies, and again, there's conflicts of interest with any particular study, but some of the studies historically have been designed or developed by manufacturers or pharmaceutical companies. So there's some inherent bias. And again, well, you might say, hey, what's your bias? And, I'm an orthopedic surgeon. I don't have an interest in a particular pharmaceutical company. However, my bias was that I use aspirin. I think one of the other co-authors, Jay Parvizi, is also a heavy aspirin user, and he's been a large proponent of aspirin for the last decade plus. So you might say we have, at least 2 authors who come at this study from an aspirin bias perspective. And, that may be an important thing to discuss as well. We do reference in the paper as well the 2022 ICM, or International Consensus Meeting on VTE. And for the audience and for the students and the trainees and even surgeons out there who are not familiar with it, I would say take a look at that, because that's sort of a global consensus meeting that takes different topics, including things like use of aspirin as a DVT prophylaxis measure, and sort of does a Delphi consensus structure to say, is there best available evidence? I would say one of the outputs of that did recommend aspirin as a VTE, as a very effective VTE prophylaxis agent, including those in moderate and high risk groups. So again, that sort of was a sort of a impetus to say, hey, can we test that hypothesis or test that, expert opinion, consensus, review of the literature in another large scale population and go from there. But, again, that was a little bit of the study design and the purpose of using a large scale data set. But again, I think, I think worthwhile to just, as I said, highlight some of the either personal or the sort of the perspective behind it. I'm saying, well, let's see how good aspirin lines up against other measures. So.
Now, you mentioned some trends towards aspirin and the international consensus coming to that conclusion, as well as your own personal thoughts on this topic. So, and I'm not sure how long you've been in practice, but is this something that you have been utilizing for DVT prophylaxis, meaning aspirin, or were there other agents that you were using that you had switched to after diving into this topic more?
Yeah, so that's an excellent question. I kind of alluded to a little bit in my preamble because, in the last decade of practice, I've used predominantly aspirin, but I had used some Lovenox as well for my joint replacements. I had trained, and this is going back a little bit of time, but I had trained at some institutions, for example, in Philadelphia, where Coumadin was a standard for a lot of the joint replacements. And I do recall, as a trainee or, resident, daily, looking at IRR levels, trying to titrate Coumadin. Again, of course, patients were in the hospital several days at that point, but it was something where now a little bit it's, aspirin's plug and play. I give it to them and I kind of like that convenience. I think, another topic for discussion here, and I always consider this, and, it's not simply preventing DVT as we're focusing on here, but it's also looking at things like bleeding complications and looking at wound drainage. So I always, and again, this is, my perspective and my take was that aspirin had a really nice profile of, in my hands, and then, certainly in talking with others, it had a nice profile of preventing DVT, but then also had a nice profile as well for minimizing complications such as bleeding, any sort of undue wound drainage. And then again, the ease of dosing, the ease of monitoring, the ease looking at that from that perspective sort of was a happy medium from all perspectives. But I do think, again, bringing that to the table, aspirin has been my predominant DVT prophylaxis measure for patients. Now, if someone comes in, on, having a stent a year ago and they were on Plavix plus aspirin, I mean, I don't rock the boat too much on people who come in with specific regimens for their, cardiac medications or some other reason why they would be on a different type of anticoagulant. So I will tend to keep those patients on those medications. But again, someone who comes in naive off of a chronic anticoagulant, I will use aspirin as the default rather than using something else. So, and that's a little bit of my practice, and that's been going on for a number of years. Yeah.
Yeah, mine's kind of changed over time. When I first came into practice, my partner was using Lovenox injections for 3 weeks at that time, which was longer than I had experience with, where we did it for 2 weeks in residency and fellowship. Yep. So I didn't want to be too disruptive, so I just kind of said, okay, I'll roll with that. There were some problems with it being expensive, some problems with people not wanting to do the injections or not feeling comfortable doing the injections, of course. And then you have the occasional patient that bleeds, and the first thing you have to do is stop your anticoagulant, and then you're concerned that they're not protected from VTE, but we can't have them bleeding either, and all these issues that you bring up. So that partner that I had subsequently went on to a different practice. So I then switched back to 2 weeks, which everybody was happy about, that we moved to 2 weeks. And then after a while, the people were just tired of the injections for the most part. So I switched to rivaroxaban over to Xarelto. And in the last several years, that's been my agent of choice. I've used aspirin very infrequently. I leave people on it if they're already on it, but I haven't been using it for the DVT prophylaxis after surgery on a routine basis or even on a risk stratified basis. And my main concern was, I just wondered, like a lot of us do, whether or not there was the efficacy there for aspirin versus the other kind of quote heavy hitter anticoagulants. And it's just anytime you take something back away when we're treating patients, you get concerned that, if I have a complication, 2 weeks later, then I wonder if I just caused that trying to get away from something that I wasn't really having a problem with. So I've been watching closely as more and more data has come out about aspirin, and I've tried to be kind of a slow adopter when it comes to this. But get a little bit of pressure from the hospital to decrease cost by using aspirin, and I don't particularly like when my patients call and say, "Hey, this costs a few $100 that I don't really have to spend on this." So that's where I've really thinking about switching, and have just been waiting for a couple more studies to come out, and really for myself to look into it enough to be to justify it to myself. So let's dig into this study, if you don't mind, for the next several minutes here, and kind of talk about the specifics of this study. So with that kind of as a background for the environment around VTE prophylaxis and joint replacement, tell us about the specific methods of your study and how you chose to evaluate this problem.
Yeah, so I think, again, on the focus of we need some big data set here, we use what's called the TriNetX collaborative network. It has a number of centers, and then again, probably close to 90 million patients that are in this data set. We decided to take a look at patients receiving their total knee. We wanted a broader time frame, so we looked at from 2012 to 2022. And again, that was to try to see, we wanted to see trends over time, and then also try to look at rates of complications in a robust fashion. We took a look at patients at high risk for VTE, and those were defined as patients, again, through the international consensus meeting. These are patients who have, sort of different risk factors that would put them at higher risk, including things like obesity, primary thrombophilia, things like history of stroke or COPD. And, there's a laundry list of things that might put someone at a higher versus lower risk. And, we really separate those. After doing that, we probably had roughly close to about 50,000 patients in each of those arms, the high risk arm and the low risk arm. And then within each of those arms, we try to take a look at the DVT prophylaxis. So whether it was low dose aspirin plus another anticoagulant, which is the smaller groups in each one, then the majority of the groups were either low dose or the other sort of anticoagulant prophylaxis. And these are the ones like, the warfarins and the other ones you mentioned as well, unfractionated heparin, the factor 10A inhibitors, the direct thrombin inhibitor. So, those were the other buckets. And we did that for both the high risk group and the low risk group. And probably about 20,000 patients in each of those arms of the comparing the low dose or the, low dose aspirin to the other anticoagulants. And so those were the ones where, we applied propensity score matching to kind of match them as well. And some of your questions or thoughts from before, like there was looking at characteristics such as chronic aspirin use and some other heart disease issues. And so we really tried to make sure that each of the buckets were comparable when we did the propensity score matching. And then again, in terms of, things like just curiosity, we said, well, what are their use of rates of aspirin versus other anticoagulants in total knee over time? And there's a figure in the paper that you may recall that looks at the increasing use of low dose aspirin, and then also the decreasing trend over time from over the last decade of the study, 2012 to 2022, of the other anticoagulants. So a little bit of reflective. Now are these just trends in orthopedics? Is this something? But over that decade, there was definitely a decrease in the sort of bigger gun, so to speak, of anticoagulants. So it kind of reflected a little bit of what we had a sense of perhaps in the orthopedic literature, orthopedic field, that there may be sort of a uptick in aspirin use. As the chest guidelines and things of that historically had been not including aspirin, and then perhaps between the orthopedic community using aspirin more or testing it out, plus some of the other guidelines that were there, plus our academy. I think, some of those things, I think some of those forces definitely were reflected in the fact that, aspirin use, both in low and high dose aspirin use, was increasing over time, specifically the low dose aspirin. I think other kind of interesting things, if we look at it, the rates of DVT and P within the 3 months after TKA for all patients actually, fell over time, in both DVT and PE from that 2012 to 2022. So I think it's something where the rates had come down as well. Now, I think there's probably, and we bring this up in the discussion, but, is this because we're doing more rapid recovery protocols? I don't think our patients are necessarily becoming healthier. I think it may be a fact, a fact of probably more rapid mobilization, probably better preoperative optimization. But it was interesting as well. The rates of DVT and PE are overall falling, even in the sense in the light of now using a little bit more aspirin over time. So, we're not that specifically wasn't a conclusion that the aspirin was the cause of this. I think it was more multifactorial. I think it's the rapid recovery, the shorter length of stay, the up and moving, the day of surgery, and all that. So I think those were sort of more just observation type things. And then, kind of digging, into the odds of actually using, prophylaxis, even in higher risk patients, we found that, their odds have been, increasing over time amongst even the higher risk groups. So, that was our kind of foundation, the kind of demographic propensity matching, the temporal trends, and then also looking at the DVD trends. Those set the stage a little bit for then specifically looking at odds ratios for comparing aspirin to, the other coagulants with respect to the complication things that we were sort of discussing in the beginning. So.
Yeah, it's interesting that the same time that we're starting to shift away from what we think are, more significant anticoagulation, we're also seeing a bit over the same time period the appearance and the boom of tranexamic acid, which all of us are worried we're going to cause DVTs when we first started using that. So it's an interesting juxtaposition as we go to what we perceive as a little bit lighter of an anticoagulant, and we add a medicine that we are concerned could facilitate clot formation, and the rates just keep going down, which is interesting. And I think it's great information, something that I really commend the orthopedic community for really studying in depth instead of just relying on, we think this is a worrisome, we think this isn't going to be efficacious enough. We're going to put it to the test with data and prove it. And I think that's been a big improvement for all of us who do joint replacements.
Yeah, and I think even just not to get too much off topic, but you bring up an excellent point about the tranexamic acid. I mean, it's been one of the game changers in joint replacement, right, and orthopedics in the sense of, I may transfuse a patient once a year or twice a year, and I do largely think it's probably due to tranexamic acid, right? I think we have better stewardship protocols, but again, yeah, I mean, I always think back in designing this study, I thought back, I did. Mark Pagnano in the Mayo Clinic wrote a paper on, and other groups have as well, on, just using tranexamic acid even in high risk patients who've had cardiac histories, and they found no really high risk of, adverse events there.
Some of those they found low risk of adverse events because a lot of those people were already on some higher level anticoagulants.
Yeah. And perhaps the bleeding control and all that. So I think whether to be a rebel or not, or just mimic some of that spirit, it is a little bit of challenging dogma and say, hey, what is it about aspirin that may be good or not? And again, I do think, the rapid recovery protocols, other things help us overall, but I do think these trends and the efficacy that we're seeing here, again, as best as controlled as we can, I think do still ring true a little bit, with aspirin being definitely a viable option,
Dr. Kamath, I'm more of the numbers nerd around here, and you're hearing these methods and reading this methodology. I thought was great. You're pulling from a system that you're measuring it by the millions is always fascinating when you have these big data sets, and then you design a well-designed study like you did, where each arm of the study has nearly 20,000 patients. So first of all, great work on that, and I thought that was set up really well. So with all that being said, methodology-wise, can you tell us a little bit about the main findings and the main takeaways from a result standpoint with this study?
Yeah. So, the main results, I think we talked a little bit about, the increase in the use of aspirin. I think what was interesting, and, we did put together a number of tables to try to compare, different regimens like low-dose aspirin versus the other anticoagulants. We looked at low-dose aspirin versus rivaroxaban specifically, and then also things like low-dose aspirin versus low dose plus a combined anticoagulant. So we try to look at different combinations, and I would ask the readership or the listenership to maybe dive into those tables to kind of look at the specific things. But when we look at complications, so to speak, we look at the main title was DVT and PE, but we looked at other things like hemorrhage or hematoma or GI bleeding, even things like mortality, revision surgery, ED visits, readmission. So we try to look comprehensively for all those comparator groups. And, when we look at, for example, low-dose aspirin versus other anticoagulant, the odds ratios were generally in favor of the low-dose aspirin groups. I think there was maybe one where it was sort of a wash. I think it was, for example, PJI was really no different between the two groups. The confidence interval crossed one for that group, but every other parameter for the low dose versus other anticoagulants across the patient profiles were actually in favor of the low dose aspirin. Some a little bit stronger, like for example, hemorrhage was more strongly in favor of the low dose aspirin group. And that gets to my comment before a little bit. Qualitatively, I've always seen less, wound complications, less bleeding at the surgical site with using aspirin versus the other anticoagulants. And then again, it's nice to see that you have an odds ratio of 0.25 or 0.23 for things like DVT PE. So fairly protective on both ends of the spectrum. And then other big bad complications, mortality, stroke, things like that, MI really were in favor, or certainly showed that aspirin was effective in kind of mitigating those complications as well. And again, this is in the first 90-day period, so fairly comprehensive. It's not just in the first 2 weeks or 6 weeks that we looked at. We sort of took it out to the 3-month period. And then, like I said, the listenership can kind of dig into the meat of the other kind of comparator groups, including things like rivaroxaban only, and then again some of the other parameters. So I do think there are, within the limitations of trying to get as many patients as possible, and despite having tens of thousands of patients, I think you can always kind of challenge your question. And then even I think there may be folks who may look at our propensity matching or other parameters. But again, like I said, the best we could do with the study available data points, fairly robust study, and again points that low dose aspirin definitely performs well. So I think that's sort of a major findings of the study, that both low risk and high risk patients in the low dose aspirin group had decreased odds of the bleeding, the complications, and even things like hospitalizations.
Yeah, I thought all those results were right on the money. The things I was worrying about, people are going to get no more DVTs? No. People are going to get more PEs? No. Am I going to kill somebody if I use this medicine instead of the other ones that I'm using? Absolutely not. Do I need to risk stratify people? And it seems like the answer is pretty convincingly no. And then, of course, we can go down the line to the complications as well. And even those things are equal enough that we can start to assess cost as well. And I want to bring cost down like everybody else, but when somebody comes to me leading with how does this cut cost, I always respond with how is this beneficial to the patient before we start thinking about how it benefits me, or how we think about how it benefits the healthcare system cost wise. And just across the board, the aspirin performed in all categories, as well as causing less complications. So great paper. And a lot of times when we get these big database studies, one of my big frustrations with studies like this, to be honest with you, is it's a lot of times we do a lot of these big elegant studies with a bazillion patients in, all to find that there's no difference in anything and that we haven't really learned much. So I was happy when I saw the results of this study and really reviewed them closely in preparation for this, to see that this is some really good information that we can use in our practices. So I guess I'll pin you down now, and yes or no, can we confidently say that aspirin's our preferred DVT prophylaxis agent in all risk groups as a result of this study?
Yeah, I think, from the standpoint, it goes back to a little bit of, we're creatures of habit too, right? We like certain things, and then again, all it takes is one patient to have a complication, a DVT or something that sometimes it sways our emotions on the next 100 patients or may change our practice. But I think it's sticking with this large database study that's well controlled and well designed, and really supports the use of aspirin. I would say that we can definitely continue to support this. It doesn't mean this ends here. I think it's worthwhile to study, again, especially as we look at things like rapid recovery, and then again more complex and more comorbidities with our future patients. These are all things to continuously look at this. So I don't think we rest, or I would say I rest on, okay, this is the be all end all in my practice. I'll continue to challenge this. I do think there's other regional and other biases and other kind of understanding. I will tell you that in response to this paper, a number of folks from around the globe actually have written to me, and some have written letters to the editor, some from Europe who do not use aspirin in certain countries and then don't believe in it, and then some that are in support of it. Again, so it's not just a US question, it's a global question. But I to the point of, a very efficacious medication that has a great profile on both ends of the spectrum, bleeding to clotting. And then again, to your point about, cost, if it's cheap, if it's readily dosed, if it's now better understood, and it's best for the patient as well as ease on the health system, I think it's sort of a win-win. So I would say that, aspirin, in my mind, clearly has a strong role and, really should be given consideration as first line therapy for DVT prophylaxis and total knee replacement.
Hey, you made a good point about this not being just a U.S. problem; it's more of a global problem. But bringing it back to the local nature to it, I know you said and I think you said Dr. Parvisi was also using aspirin even prior to this study. But I was looking at the author line, and it looks like there's 7 or 8 authors there. Have you talked to any of your co-authors or anybody within your own health system that have since changed their prophylaxis to aspirin based on this study?
Yeah, so some of the co-authors, one is more on the statistical side, but I would say just in general, like our institution is a heavy aspirin use institution, and we tried to standardize as well. We have a lot of surgeons, we have a lot of, thousands of joint replacements going on, so we try to standardize a lot of things, but our general consensus is aspirin for primary and actually a number of the revision surgeries as well. And so, again, we have certain parameters where we'll use the other anticoagulants, but in general, the aspirin has become the default at our institution. I do think in chatting, at conferences, chatting with different surgeons here and there in different venues, and then also in the spirit of putting this paper together, I do think, aspirin has become more widely accepted. And again, I don't appreciate, again, this is more anecdotal, but in discussions with folks on the small scale, little conversations, visiting a hospital or at a conference, they're experiencing the same beneficial safety profiles that we're seeing here in the study. So I do think, a lot of folks have moved towards this. And again, I'm a big advocate of it. I've always has been, but I think this really supports that and at least opens the door for discussion and at least opens the door for looking at our data and saying, hey, does this ring true with my practice? Is this an opportunity to understand this? And then again, maybe start slowly with patients that you think may be the lowest risk of introducing aspirin and not having complication, and then start building that up or working that into more routine practice as your health system, as the patients get comfortable with this type of modality.
I'm going to go rapid fire at you with a few questions, and these are going to be kind of short answer questions so we can cover a bunch of stuff in a short period of time, little nuanced things. The short one, do you use this with TXA? I assume the answer is yes from our discussion so far.
Yeah, standardize again, so 1 gram on incision, 1 gram on closure. And this is pretty much for everyone.
Yeah.
I think there's some rare contraindications like color blindness or things like that. But again, it's the default, everyone gets it. TXA and aspirin pretty much.
How about bilaterals and revisions?
I tend to do very few simultaneous bilaterals. I'll tend to stage them, but again, for closely staged, and then again, some of my partners do a little bit more bilateral work. We'll tend to use aspirin as well for primaries. For revisions, obviously, as there's a whole spectrum of revision surgery. Again, there's simple ones like the poly swap, so to speak, versus, the big, huge, massive cones and stems and things like that. I tend to bias, my use of Lovenox more in the more bigger surgeries. And then again, more quote unquote simpler revisions get aspirin 325 BID for 6 weeks.
For your standard patients, though, it's 81 milligrams twice a day. Is that correct?
Yes, and I use it for 6 weeks. Now there are some in our group who do it as short as 4 weeks, but that is something I think that was asked, how has my practice changed over time? But I have not changed the duration of using it, sort of starting it some time ago. So I think probably can truncate it. Whereas I started 325 BID for 6 weeks years ago, I went down to 81 BID. I'd still kept it at 6 weeks. Now perhaps maybe I could truncate it further, or those who are running around a clinic at 2 weeks, maybe I could even stop it then. But that's just, again, my by internal caution. And again, as we dive into future studies, maybe there's some way to very specifically look at that question. Can we do it for 2 weeks and get them off? And I don't have that answer for you today, but it would be interesting to say that. I just don't have the confidence to say that with the available data.
Yeah. Rolling on with rapid fire questions and answers. Do you use this with anti-inflammatories in your post-op patients?
Yeah, things like Celebrex can be used in conjunction. I know, we don't load up on the, other ones, but once we get them off the aspirin, they can go back on their anti-inflammatories.
They use them at the same time. So I send people. I use a lot of Toradol when people are in the hospital. I send them home on meloxicam. If people are on daily aspirins, I don't alter anything. And actually, I use Xarelto if they're already on daily aspirin. I let them use that, and I leave them the meloxicam. And personally, I've not shown that, not had any bleeding problems with that. I was just curious if you stop people's anti-inflammatories in the early time after surgery while they're on their aspirin.
Yeah, we let them. I don't load them up too much, but we do let them. I may not be as liberal as you with the Xarelto and plus that and all that, but I think, again, I've not seen any major issues using them in combination. Yeah.
And how about with other things, like if people are on aspirin and Plavix, for example, or I've had a couple of people that have been on aspirin and even some of the other heavier anticoagulants. Do you go ahead and just give them both if that's what they're on regularly anyway? Do you restart their home medicines, I assume?
Yeah, I'm actually pretty or fairly aggressive. You might say I just start them right back on their home dosing the day after surgery. And again, if in the rare patient that I use Xarelto or something, I have some partners who might start them at half dose for a day or two, but I just restart them back, because I do think if that person is on a specific medication chronically for a valve or something, they need to get back on that very quickly. It's also a discussion preoperatively. And then some patients need to be on their anticoagulant, like a baby aspirin, right up until and during surgery for cardiac reasons. I roll with that as well. I think, between TXA and obviously good surgical technique, I think we can mitigate a lot of the bleeding. But again, I'm fairly aggressive on getting them back fairly quickly.
Last but not least, unless they have a mechanical valve or some other reason they've been on it for years, can we relegate Coumadin to the trash bin of history where it belongs?
A little bit of PTSD or heartburn just thinking of all the Coumadin dosing and getting calls from nurse in the middle of the night and trying to predict an INR level. So if I can put that to bed, yes, I'd be a happy camper. And again, it has really no role in my practice, but I don't want to speak ill of those folks, because again, it was our mainstay for a long time or fun. So.
I hate warfarin, and I hope to never write the word warfarin on a chart for the rest of my career. That'd be A-okay with me. So, well, as we wrap up here and kind of summarize your findings, what are just a couple quick take-home points for our listeners before we wrap up?
Yeah, take-home points. I think low-dose aspirin is highly effective in mitigating DVT and VTE complications. And it holds itself up in kind of head-to-head competition, so to speak, with other anticoagulants, quote unquote, stronger ones on the market right now. So it has a really nice profile of doing what it says it does in terms of preventing clots, but also not causing undue harm from bleeding complications or other complications. It's predictable in its dosing. It's cheap. It's cost effective. And I think from my standpoint, this data and this paper further supports routine, if not the default use of aspirin in total knee arthroplasty in 2024.
I think you convinced me. I've been on the fence about aspirin for a while after reading this study in detail, talking with you tonight. I think you converted me. So tomorrow morning, I'll go start the wheels turning on changing that at our shop as well. So Dr. Atul Kamath, thank you for joining us from the Cleveland Clinic to talk about aspirin in VTE prophylaxis after total knee. Great topic, one that I think we can all learn from. And like I said, I read a lot of big database studies like this that I'm then sad that I've spent 20 minutes reading a study with a lot of statistical jargon and things, all to tell me that it didn't find anything, that we don't have any more clarity than we had beforehand. So this is one that I do think is clinically applicable. And I thank you and your co-authors for doing it. And thanks for joining us.
Thanks a lot. I appreciate it. Now I got another podcast to subscribe to. I'm excited to keep following you guys along, and you're doing great work. And this was a great fun session. Thanks so much.
I echo that exactly, those exact points. So Dr. Kamath, thanks a lot for bringing this topic and this great paper. It was fun to read and definitely a fun discussion with you. So if you want to get a hold of us, you can reach us on Twitter and Instagram at the SKC Podcast. You can visit our SKC Podcast YouTube and Facebook pages or email us at the skcpodcast@gmail.com, and we will talk to you next time.